not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He, got his wrist pain by doing over-aggressive high fives to his buddies.
Welcome to the Emergency Ultrasound Podcast. My name's Mike Mallon. I'm here again with Matt Dawson. And my goal today is to bore you to tears. We're going to talk about diastolic function and evaluating the diastology using bedside echo. Matt.
No, sorry.
Wake up, man. Come on, dude.
Sorry to sleep. Go ahead.
Jeez. So we're going to talk about evaluating the diastolic function of a heart using bedside ultrasound. And this is not one of our more novice lectures. This is definitely one of the more advanced lectures that we're probably ever really going to have on this podcast. So we figured we'd go ahead and knock it out of the way now, so hopefully those of you that fall asleep will maybe give us another chance and come back. So getting started, we're just going to talk a little bit about heart failure. So diastolic heart failure is basically typical heart failure that just means that the heart doesn't work well in diastole. So you can have systolic heart failure, you can have diastolic heart failure, you can have both at the same time. The trick is that about 5 million Americans have heart failure and about $29.6 billion are spent on admission for heart failure in the United States, which is 3% of our total healthcare budget. That's not chump change. That's a pretty big deal. So this is a pretty important area for us as emergency physicians to have some knowledge about. It turns out that about half of the heart failure patients are diastolic failure only, which means that they have a normal ejection fraction. So their ejection fraction is 50 or 55%, but they still have pulmonary edema. They still present to the hospital with the same symptoms, and a lot of them still need to get admitted and diuresed. So 2.5 million people in the United States who have diastolic only failure.
Did I miss what diastolic heart failure is?
Yeah, you missed that. We went through it for about 15 minutes a second ago. You were asleep.
Okay, sorry.
No, Matt, we haven't gotten to it yet. Diastolic failure is basically where the heart can't relax, and we're going to talk about that in a minute, okay? Oh. So heart failure can present in a lot of different ways. It can be pretty challenging to make the diagnosis because patients tend to have symptoms that are, just sort of general, like dyspnea, fatigue, pulmonary congestion, edema. Some of them even present with Dawson syndrome, which includes weakness and malaise.
You forgot the explosive diarrhea.
And sometimes they have explosive diarrhea too. So it can be pretty challenging, and it turns out that your physical exam pretty much just sucks. So sensitivity of JVD, 30%. JVD, do you know what that is, Matt?
I think I heard an attending at the VA say something about it one time during medical school.
Yeah, I can't really remember either. Sensitivity of S3, I think that's just a nice car, isn't it?
Is that a Mercedes?
Oh, I think it's an Audi.
Oh, okay.
Anyway, your sensitivity of S3 is about 24%. So I'm not going to hang my hat on the physical exam here, although, that's what we've done a lot in the past. So this is sort of an interesting way to add a new piece to your armamentarium.
So let me make sure I understand that. You're saying JVD and S3 have traditionally been things that we use to make the diagnosis of diastolic heart failure or heart failure in general?
Just heart failure in general. Okay. So that's neither of those are really specific to diastolic.
But only 30% of the patients actually have that?
Yeah.
Those two things. Okay. Mm-hmm.
Well, around 30.
Okay. So I'd only miss 70%.
That's not bad. That's pretty good for Dawson.
Okay. Yeah.
All right. So where do you come in? So I think it's important that you know how to do this so that you can help yourself make the diagnosis of diastolic heart failure. And then because diastolic heart failure is probably going to become even more important in the future because the AHRQ is pushing for patients with heart failure to become candidates for outpatient therapy. So up to 50% they think are probably candidates for outpatient therapy, and diastolic function is going to be really important when it comes to that.
So if I miss all of these and send them home, then I'm doing the right thing,
about
outpatient therapy,
half
right?
the time, yeah.
All right, good.
Half the time you're doing the right thing. So, the proof is in the pudding, right? So here's the pudding. This is a pretty cool study that was in Academic Emergency Medicine, and this is, I think, out of Boston, if I'm not mistaken, 2009, and this is a study of 145 patients evaluated by ED docs using echocardiography for restrictive diastolic dysfunction and compared that to BNP. And what they found was pretty amazing. They found that pulse Doppler was about 82% sensitive and 90% specific. And even cooler than that is they showed that it was better than BNP or the Boston heart failure criteria at diagnosing acute heart failure in these patients.
So if this sounds like something that is pretty serious to diagnose, and if the sensitivity is only 82%, that worries me a little bit. But you're saying, are these other things, this Boston heart failure criteria, what is the gold standard for that? What do we use now?
The gold standard they used for this study was basically cardiology's diagnosis.
Okay, so I actually don't have a cardiologist always sitting in my AD, so I guess this would be helpful.
Yeah.
Okay, I got you. So now if I just knew what diastolic heart function was, I
told you, you missed that part. You can go back and listen to the podcast.
Sorry, I'm going to get some pudding.
All right, wait, there's more.
No, Mike, you wait. Now, I feel at this point that it's kind of important to do a quick summary. What has Mike taught us so far? First off, this is a really important diagnosis, diastolic heart failure. 5 million Americans a year have this, and $30 billion a year is spent on it, so it's pretty important. He also told us that our history and physical exam are unreliable. So sure, I mean, back in the old days when that's all you had, go ahead, use your history and physical exam, and of course today, still take a history and physical, and if it's obvious on history and physical, great. But we've got something a little better today. We've got bedside echo. And Mike showed us a pretty cool study showing that emergency physicians can evaluate for diastolic dysfunction, and it turns out to be a little better and a little more accurate than BNP or the Boston heart failure criteria. So now, Mike, I still have no idea how to do this and how exactly to use it, so please tell me, or I'm going to get very angry.
That's not the only thing. So diastolic heart failure and acute heart failure exacerbations are not the only thing that you're going to use this for. And I think once you get through this lecture, you'll hopefully appreciate that diastology really tells us a lot about preload. And it tells us about how much fluid is getting to the left side of the heart and how we need to treat those patients that are critically ill. So patients in sepsis, diastolic function becomes important. And what you can actually do is you can use your diastology and your estimation of the diastolic dysfunction, and it actually can give you a number for your wedge pressure. Now this is an estimate. It's not a pulmonary artery catheter. It's an echocardiogram, so it's not perfect, but it can get you a lot closer than your physical exam is, or a BMP for that matter, as to what your wedge pressure is going to be in your patients.
Has that estimate been compared to actual wedge pressures? Now,
Yes.
maybe I should ask you these questions before you start the lecture.
No, it has.
Oh, it has?
Yeah, it
I
actually
know
has.
this.
Yeah.
Okay.
Yeah, E over E prime is highly correlates with wedge pressures measured on pulmonary artery catheters.
I feel like you just made that up.
Maybe I did. You're not going to go look it up.
No, you're right. Okay.
So
I believe you.
Not only that, but big hearts do better. Diastolic function is important for evaluating the size of the left ventricle and how well it's filling. Turns out that big LVs actually do better in sepsis. So this is important not only in our patients with acute heart failure exacerbation, it's also important in our really critically ill patients and when we're trying to figure out what's next. More fluids, more pressures, how do we manage this patient? That's when it's really going to help me.
Is this so? Okay, so I'm a simple man, Mike. I for my preload, and I like to look at the IVC. Is this better than me just taking a look at the IVC?
That's the $1 million question, Matt. I'm not sure that I have the data to really answer that definitively, but I think we can talk about it for a minute. The difference is you're sort of asking two questions. When you're looking at IVC variation, you're looking at preload to the right side of the heart. When you're talking about left ventricular diastolic function like we are today, we're talking more about preload to the left side of the heart. So the trick is that there can be things that sort of make the two not really correlate. For example, right heart failure or pulmonary hypertension, pulmonary embolus. Anything that's going to cause backup of blood on the right side of the heart while causing or preventing forward flow of the same blood to the left side of the heart is going to give you a difference in right ventricular preload in comparison to left ventricular preload. So in the healthy patient who doesn't have any myocardial dysfunction or history of heart failure, I think IVC is perfectly adequate. The question is, what do we do in these patients that have septic-induced myocardial dysfunction? What do we do in those patients that come in with a history of heart failure, that sit at home, eating Doritos on the couch with a CVP of 15 at baseline? Do they need more fluid? Do they need diuresis with their sepsis? I don't think so. That's not the answer. But the thing is that when you have that baseline heart dysfunction, it really becomes more important. You want to look more at the left ventricle and understand what the preload to the side of the heart that's perfusing the organs is. That's the area that I'm really interested in. I really want to know, do I need to give my left heart more fluid? Is there too much fluid on my left heart? Am I past that point on my Frank-Starling curve? Do I need to start giving dobutamine? And I think that's where diastology comes in, and that's why I tend to look at the diastolic function on every septic patient that I see.
So this is taking preload a whole step further, past IVC, past CVP, and it's basically, in essence, giving you an ultrasound pulmonary artery catheter measurement.
Okay. Yeah, so I was planning on just tuning you out the rest of this, but that actually sounds pretty useful.
So let's do it. Let's talk about some diastology. So what is diastology? Diastology is basically the diastolic function of the left heart. The left heart has to relax and it has to comply. And the ability of the myocardium to relax during diastole becomes very important, and the ability of the myocardium to comply and accept a blood of volume during diastole also becomes very important. A hard, stiff heart that doesn't take blood very well is just going to have a very low cardiac output, whereas a heart that's very soft and pliable is going to be able to take as much volume as you want to give it and still give you a good cardiac output from it. So it becomes a measure of how hard your atria have to work, how hard does your pulmonary circulation have to work to give enough blood to the left heart to give you a good cardiac output.
Thank you. Over 10 minutes in, we finally defined diastolic heart function. So what is it? It's the performance of the ventricles during diastole. That's what diastolic heart function is. More specifically, it's the ability to relax during diastole and the ability to comply or accept a volume of blood in diastole. Now, what else did we learn in the last few minutes? Well, we learned that diastolic measurements can be a better estimate of preload, especially to the left heart, maybe better than the IBC, which is what most of us probably use right now. And we also learned that diastolic function can be a prognostic factor in sepsis in the critically ill patients and can possibly help us to know how to treat those patients. Is that right, Mike? Tell us more.
So here's an example of a heart. This is a normal heart, Matt. So in this particular heart, what do you think the systolic function is? Is it good? Is it bad?
64%.
Yes, it's exactly 64%. First measured at 64.3, but then we corrected that after a couple
I like to round.
So this is normal systolic function. And I can also tell you, just looking at this heart, that this heart probably has normal diastolic function. And that's because it's got good descent of the base. So the base is this area where the valves insert into the septum, and that base right there tends to be moving really well during diastole. So as that LV is filling, there's a lot of descent of the base. That tells me good diastolic function.
So we're done, right? Good diastolic function.
Yeah, you can go home.
All right.
Compliance is the ability of the myocardium to accept a column of blood during diastole, and it determines the pressure required for diastolic filling. So the compliance is the next piece, and this is the piece that goes really to crap when you get bad hypertension or when you get fibrotic disease of the heart or interstitial disease of the myocardium. And once that compliance goes to crap is when you're really going to start having diastolic dysfunction. So what's the physiology? How do these people go from having normal, pliable hearts to having crappy, hard hearts? And the reason it occurs is usually because of hypertension. There's other reasons, but the main one we're going to talk about is hypertension. And just to briefly hit on it, hypertension leads to a thickened LV. A thickened LV leads to decreased left ventricular filling in diastole because it can't relax well, it can't comply well because it's thick and it's hard. And decreased filling leads to decreased cardiac output. Once you start having decreased cardiac output, you're not getting enough blood flow to the kidneys. That activates your renin-angiotensin system, which then causes fluid retention, and fluid retention leads to increased preload. Increased preload is the same thing as increased filling pressure, and increased filling pressure is the thing that causes blood flow back up in your lungs to cause pulmonary edema and acute heart failure exacerbations.
And when you say hypertension is the usual cause, you're talking about in the U.S., right?
Yeah, because no one else in the world has hypertension.
Right. Well, but I'm just saying that there's other causes of cardiomyopathies and things that maybe in other places and other people that were practicing. I mean, I don't know if you knew this. We have an international audience several hundred countries. That's why I'm bringing this up.
I heard that. That's how we got the 3 likes on Facebook, right?
Yeah.
So yeah, there's lots of different causes, and I'm actually going to talk about those in just a second. In these 2 pictures, I just want to bring up the point that you can get admitted for heart failure exacerbation with a normal ejection fraction. And here's an example of a patient on the left who's got a crappy ejection fraction, a really low EF. They're getting admitted for congestive heart failure exacerbation. They've got pulmonary edema. They've got increased JVD. They've got a BNP of 1700, whereas the patient on the right, although they've got a good ejection fraction and they've got pretty good squeeze of the LV, they've got crappy diastolic function. So there's hardly any blood actually going into the left ventricle to get squeezed out. And because of that, they are also getting admitted for acute heart failure exacerbation. They've got a high BNP. They've got pulmonary edema on their chest x-ray and on their exam. Same presentation, 2 totally different looking hearts.
And you're telling me we should treat these differently?
I'm not telling you that.
Okay.
I'm telling you should recognize both of them. Because in the long run, they get treated pretty similarly. So causes of diastolic dysfunction. This is what you're asking about, Matt. Here's your international causes of diastolic dysfunction. There's hypertension, which is long-standing, which is our most common cause in the U.S. by far. It's probably hypertension, and then cardiomyopathy, including hypertrophic and restrictive. Restrictive being things like amyloidosis and like those other zebras out there.
And we'll go into more of those causes on the versions of this that we translate into the other languages. So.
And then obesity, sleep apnea, and of course coronary artery disease can all cause it too. So those are some of the causes. So identifying diastology, we're going to have to go through this kind of slowly because it's sort of crazy and there's a lot to do. But basically we're going to be looking at the movement of the mitral valve annulus. So that's one of our subjective causes of diastolic dysfunction. We're going to look at left atrial dilation. That's also a subjective cause. And then there's these qualitative identification procedures that are probably more important in the long run because we really want to be able to tell our cardiologist, look, it's really bad or it's not that bad. And to do that, we're going to talk a little bit about using pulse wave Doppler and evaluating the speed at which blood cells run into the left ventricle and the speed at which that base of the heart descends. So subjectively, here we have a heart on the left, which is normal. It's got a good descent of the base. There's a normal-sized left atrium, whereas the heart on the right, it clearly has some LAD lesion here. The apex is down. It's not squeezing very well. Clearly. There's poor descent of the base, and there's a big left atrium. So the poor descent of the base and the big left atrium are both signs that there's probably diastolic dysfunction in this patient. The left atrial area is actually pretty sensitive for diastolic dysfunction. So if it's greater than 20 centimeters, you can be pretty confident the patient has diastolic dysfunction. And that just means there's more pressure that required to push blood into the left ventricle. So that pressure causes the left atrium to dilate. You can measure area pretty easily on most ultrasound machines by just hitting that measure button twice. Usually the next thing that comes up is the area. There are also qualitative ways to evaluate diastolic dysfunction, and there are these 4 patterns that are talked about. Those patterns are normal, impaired relaxation, pseudonormal, and restrictive. Normal being good, restrictive being very bad, and in between being the spectrum, right? So we'll talk a little bit about how to place patients into these different patterns here in just a minute. So first, talking about mitral inflow. So mitral inflow is this is the first application of pulse wave Doppler that I think we've really talked about on this podcast. So I'm just going to talk about it real quick. Using pulse wave Doppler, you're basically going to you're going to hit the PW button on your machine, and you're going to put the gate right at the tips of the mitral valve.
PW, that's pulse wave,
Pulse
right?
wave,
All right.
Pulse wave Doppler. And inside that gate, it's going to measure the velocities of the blood cells moving through the gate. Okay, so if I put that gate right at the tips of the mitral valve leaflets, I'm measuring the velocity of blood cells throughout the entire cardiac cycle, right? And here, we're going to put it right at the tips of the mitral valve leaflet, so we're just measuring the velocity of blood flow that's going through the mitral valve. That velocity of blood cells are going to move into the left ventricle in 2 different humps. There's going to be an E wave and an A wave, and that's basically our diastolic filling. E stands for early, A stands for atrial kick. Do you got that, Matt?
No, sorry.
E early, A atrial kick. It's pretty easy.
Oh,
the first
I got it.
First letter of the word. Yeah, it's crazy, huh? So typically in normal people, your E is bigger than your A. Your LV is better at relaxing and causing more blood flow and faster blood flow into the left ventricle than your atria is at kicking. Those are normal people. Okay, so the majority of your blood flow occurs during your E phase of diastolic function, and then there's just this little atrial kick, the little A wave that just kind of finishes things off for you. Okay. Typically, your A is about 1/2 your E, or maybe a little bit more than that. Okay.
I always read about 50%.
It's around 50%.
Okay.
That's 1/2.
Oh, okay. Yeah.
50%.
Sorry.
2 divided
Not
by
good
4.
with fractions.
So this is our E and our A wave right here. So this is what we're talking about. This is the mitral valve inflow pattern. So here's an example of mitral valve inflow, Matt. And now what we've done is we've basically taken an apical 4-chamber view, just like we had on the last screen. We've put the gate right at the tip of the mitral valve leaflets, and we're measuring the velocity of blood flow into the left ventricle during diastole. And that's what these 2 big humps are right here. You can see the A wave occurs right before the QRS complex on that EKG rhythm strip. See that little green rhythm strip right there? The A occurs right before it, and the E is just before the A wave. So here we have the E measured at 109 centimeters per second, and the A measured at 82 centimeters per second. You got me? So that is normal mitral valve inflow.
E bigger than A.
E bigger than A is normal.
All right.
So here's an example of the E and the A wave. We can see that it initially starts off as normal. Over on the left-hand side of the screen there, you can see that the mitral valve flow is just below the EKG rhythm strips. The mitral valve flow all the way to the left is normal. The one next to it is impaired. That's where your E is less than your A, because now your atria is having to work harder because you're starting to get some decreased relaxation of the left ventricle, okay? And your A has to sort of kick in and do more of the work. As you progress from impaired relaxation to pseudo-normal, which is that next one over, then your E becomes greater than your A again. And that's because your atria can no longer do the work, and there's increased filling pressures causing the blood to squeeze into the left heart faster. We'll get into this a little bit more. Restrictive is the last one on that little graph, and that's where your E is huge and your A is tiny.
Okay, quick quiz. If you don't understand these concepts and answer these questions correctly, then you are not allowed to go on. You have to go back, listen again. So, first up, what does the E and the A stand for, and what do those waves represent? So, E stands for early, right? What does the A stand for? Atrial. And so, therefore, what do the waves represent? Well, the E wave represents early diastolic filling, and the A represents the atrial kick, that part of diastolic filling. So what is normal? Normally you get more filling in the early stage, so E greater than A. If you have impaired relaxation, what does that look like? Right, A greater than E. And then after that, if it gets even worse, you get back to this pseudo-normal appearance, which is the E greater than the A again. And then worst of all is restrictive, a restrictive pattern, which is E much greater than a tiny little A. So the progression goes normal, E greater than A, impaired, A greater than E, pseudo-normal, E back greater than A, and restrictive, E much bigger than A. Now, if you didn't understand those concepts, go back, listen again. But actually, as I think about that, normal and pseudo-normal, both E greater than A, Mike, I'm getting scared. Help me. How do I differentiate the two?
So tissue Doppler. Tissue Doppler is what we use in conjunction with mitral valve inflow to help us discriminate between that normal pattern and that pseudo-normal pattern. So if you look right here in on the graph on the right, the second part of the graph where it says MVF, that's mitral valve flow. If you look at the first one there, the E is higher than the A, right? And then the second one, the E is less than the A, that's impaired. And in the third one, your E is greater than your A again. That's called pseudo-normal. And if you look at that, how do you really tell the difference between the first one, the normal, and the third one, the pseudo-normal?
I'd say we look at tissue Doppler.
Genius. So the way to tell the difference is by the tissue Doppler. So if you look down on that same graph down at TDI and look at that first little graph there, you've got something called E prime. E prime is greater than A prime. So I'm telling you that's normal. If E prime is greater than A prime. If your E prime is less than your A prime, as you can see, it is in not only impaired but also pseudonormal and restrictive, those three different graphs to the right, then you know that you've got increased or decreased relaxation and decreased compliance. So here, when we're looking and we're trying to compare and decide whether somebody has normal or pseudonormal filling, we have to use that TDI to differentiate between the two.
So I understand now what the E and the A mean. What exactly does that E prime and A prime mean?
Great question, Matt. So E prime and A prime is basically just the tissue Doppler, so the velocity of the tissue at the mitral valve annulus. So if you look over to the left, instead of putting that pulse wave Doppler gate at the mitral valve leaflets, I've put it right there at the annulus in between the mitral valve and the tricuspid valve. So now what am I measuring? I'm measuring the speed of tissue. I'm measuring how fast does that tissue descend during diastole. So it's basically telling me how compliant is my ventricle. That's exactly what it's telling me. The faster my E wave is, the faster the tissue's moving and the more compliant that ventricle is. The slower my E prime wave is, the slower that ventricle is relaxing and the tougher that muscle tissue is and the harder and the more diastolic dysfunction.
So it's measuring the tissue velocity during the same E and the A. So the E and the A still stand for the same times.
Correct. The E prime is just early filling and the A prime is the atrial kick. So it's the speed of the tissue descent during early filling and atrial kick.
And if the E is greater than the A, then that's always going to be normal with tissue Doppler.
Correct.
Got it.
So you could pretty much just do tissue Doppler on your patients, and if it's normal, you're done. And if it's not, then you take a look at the mitral valve inflow and figure out exactly how abnormal is it.
Perfect.
You like it?
Yep.
All right, we're doing good. So there we are. There's our TDI right there. You can see all the way on the left is normal, E prime greater than A prime. And that E prime should be greater than 8. That's considered normal, and E prime greater than 8.
Do I really need to know that?
Yes. Because if it's greater than 8, then you're done.
But can I just look at the A?
I'd go with the number 2. Because if the A is so the reason is because sometimes in restrictive, which is the one all the way on the right, sometimes your E prime is just a touch bigger than your A prime, but the velocity is really slow.
You just told me.
So if the velocity of E prime is really, really slow, like 2, then you can't just go with that. You got to look further, okay? Just work with me here. Got to be greater than 8.
Fine.
Good man. All right, so let's put it all together here. So now we're looking at tissue Doppler, and in this example, Matt, what do you think about the E prime wave versus the A prime wave? Are you done? Do you need to do nothing else here?
I think the E prime is smaller.
Yes, the E prime, you can actually see, you can cheat if you want and look right at the top of the screen and say that somebody's already measured it and it's 5.65 centimeters per second. So that is?
Less than 8.
Right? Abnormal. So this person has abnormal diastolic function. And I can tell the E prime is less than the A prime, which goes along with that, right? So now I got to look further. I got to look at their pulse wave Doppler. So TDI can be helpful not only in just telling you if there is any diastolic dysfunction, but also telling you the difference between normal mitral valve filling and pseudonormal mitral valve filling. You're yawning.
Sorry.
All right.
This is fascinating.
Yeah, I can tell.
All right, Mike, that's it. You're cut off. No more diastolic heart function talk. So we are actually just a little over halfway through this entire talk, but there's no way we're going to torture you with 45 to 50 minutes of this. So just a quick recap of the last few minutes, what we went over. We had just talked about how the E and the A waves represent the velocity of blood flow through the mitral valve and give us a picture of diastolic function. E greater than A can be normal function, or E greater than A can represent pseudonormal function. So to differentiate those two, we do what's called tissue Doppler. Instead of looking at the velocity of the flow of the red blood cells, we're going to look at the velocity of the actual tissue. And then, for a normal pattern, you're going to get E prime greater than A prime, and the pseudonormal pattern is going to be A prime greater than E prime. So that's how we're going to differentiate normal and pseudonormal filling. And now remember, if you just did the tissue Doppler and the E prime is greater than 8 and greater than A prime, then you're done. That's normal diastolic function. So that's a lot to digest. I would recommend listening to this again. I know I'm going to have to listen to it a few times to totally get it all. And next time we have a podcast, it's going to be all the good stuff. We're going to actually show you how to use this and give you case examples of where it could be useful. So tune in next time. Thanks for listening. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.